Hi everyone, welcome to another episode of our multi-heart lecture series. Today is a great pleasure to have Dr. Friedrich Verbruch that will be speaking about cardiac dysfunction in aortic valve stenosis. Dr. Verbruch is a cardiologist and intensive care physician with dedicated interest in heart failure, exercise hemodynamics, and cardiorenal physiology. He graduated as MD in 2010 from in Belgium and then completed his PhD in 2015 and then received a Master in Science in Clinical Trials in 2022 from Oxford University. He is currently employed as a clinical head clinical professor at the University Hospital of Brussels, where he cares for patients with heart failure and cardiac devices, attends the cardiac intensive care unit, and runs the exercise physiology lab. Dr. Verbruch currently serves as a deputy editor for European Heart Journal, Acute Cardiovascular Care, and is an editor consultant for JACC Heart Failure. Thank you very much for taking the time and showing us a little bit of the amazing work you're doing.
Thank you very much for the nice introduction. It's a real pleasure to be here with you. I've watched some of those episodes you are posting on YouTube, and they are all excellent talks. I will do my best to keep up with this great series. So these are my disclosures. Let's see. Yeah, okay. These are my disclosures. None of them are really relevant to this talk. So when talking about aortic stenosis, I think we should always present this pivotal figure by Dr. Ross and Dr. Braunwald already from the late 60s. It's probably the observational study, because it's not a trial, that had the biggest impact on our guidelines. And it really described the situation of aortic stenosis in 68. So basically, it was an observation of series of patients, then with aortic stenosis mainly caused by rheumatic heart disease. And it showed that those relatively young patients with rheumatic heart disease and aortic stenosis, they had a very long period where they were asymptomatic, and then when they had symptoms, they declined very rapidly, and the three cardinal symptoms then were angina, syncope, and heart failure. So basically our main recommendation to treat aortic stenosis has been based on this observation, and we observe aortic stenosis until it becomes severe, which is defined as a mean gradient above 40 or a velocity above 4, and when there is an emergence of symptoms, and then there's a class 1B for intervention. Now, we should remember that at the time that Dr. Ross and Dr. Braunwald wrote this paper, there were not that many treatment options. There was the beginning of surgery, then with very high mortality of 5 to 15%. Echocardiography had yet to be established, so it was very difficult to assess and grade the lesion severity at the time. So things have changed a lot, and this is the situation now in 2020. When you look at calcified aortic valve disease, it has increased markedly in our Western countries, not so much in the developing countries, but in the Western world, you can see that calcified degenerative aortic disease has increased markedly. And of course, those patients, they are older, they have much more comorbidities, so the disease has become more complex. This is the same figure, which shows you that it is mainly in high socioeconomic countries that there is a massive expansion of calcified degenerative aortic valve disease, and that's because there is a longer survival of these patients, also survival from heart disease. People get older there, and then you get more degenerative diseases. You can also see that it's much more than mitral disease, and especially more than than other valvular disease. So we are in an epidemic of aortic stenosis. What you also can see is that over time, and this is figures worldwide, rheumatic heart disease is still the most prevalent cause of valvular disease, but it is rapidly declining. And if developing countries will get to higher socioeconomic conditions with a longer life expectancy, eventually calcified degenerative aortic valve disease will take over as the main disease. What has remained is that symptomatic severe aortic valve stenosis is a killer. So here you can see a more recent study showing that if you have symptomatic aortic valve disease, which is severe, then you have a poor prognosis with surviving only 50% after 3 years. So what has really revolutionized the field is first the emergence of echo since the 60s. So this has made it possible to diagnose aortic valve disease more easily, and also grade it and follow it up more easily. And then more recently, we have, of course, the treatment, which has expanded considerably with a lot of transcatheter options there. So some of the valves are shown here. And this, of course, had a major impact on the risk of patients to become treated. This is a study which was actually just presented at the ACC, so one of the latest TAVR studies. What you can see, this was in patients with low to intermediate risk, and it compared the surgical aortic valve replacement with TAVR, showing that TAVR had a lower risk when compared to stroke or death from any cause, and also all-cause mortality. But look at those numbers. If you see that after 1 year, the risk with having a TAVI, it's only 2%. So remember, in Braunwald's early days, this was 5 to 15% with surgery. So we have dramatically decreased the risk of our interventions for aortic stenosis interventions. But at the same time, we are confronted with older patients with a lot of comorbidities. So in the early days, young patients with rheumatic heart disease, the valvular disease was really the only disease they had. Their ventricle there was relatively young. There were not comorbidities influencing that ventricular performance. So when they got symptomatic, it was almost sure that the symptoms were due to the valvular problem. So this is no longer the case. So we can intervene at an earlier disease stage probably now because our treatments are less risky, but the disease itself definitely got more complex. So when we think about severe AS and how we define it, so classically I've said to you in the guidelines, it's defined as a velocity more than 4 or a mean gradient above 40. And you can see here in this study that these are patients who really have a poor prognosis, while patients with a gradient that is with a velocity that is less than 3, they have very excellent outcomes. But I have here on this slide also put the survival of TAVR patients, which is at 2% at 1 year, and you can appreciate immediately that this is even a little bit better than the curve for patients who are in the intermediate velocities of 3 to 4. So basically, if you have a patient with a severe AS nowadays, your treatment is as low risk very often that if this is a patient who doesn't have competing risk and is likely to going to survive longer than 1 year, Maybe it is worth even intervening when there are not yet any symptoms. So I'll come back on this later. On the other hand, so the curve of 3 meters per second is even better than the TAVR survival. So this is probably where you should back away. There are excellent outcomes there. And then there is the most difficult group who are in between 3 and 4. And maybe we should phenotype these patients a little bit better. I'll come back on that. So natural history of severe asymptomatic AS. So these are all big studies that have been published over time. And they are all pretty consistent in showing that once you have a really severe AS, then the outcome it's really bad. And it is driven by cardiovascular mortality. Again, here you can find what is the TAVI survival after 1 year in a patient with low to intermediate risk. Of course, our guidelines, they recommend treatment of severe symptomatic aortic stenosis, but what about asymptomatic stenosis? There you can see that there are a few things which you could consider symptoms. It's of course, not every patient will mention the symptoms from their own, so you can put them on a bike or a treadmill and let them exercise. And when they are symptomatic, then you have established the symptoms. Also, when they have a drop in blood pressure, I would consider this as a symptomatic patient. And then there are basically some clues where you can intervene in asymptomatic patients when there are signs of extravalvular cardiac damage, high BNP levels, very severe AS, severe valvular calcification, or decreased systolic function. And this is basically based on observational studies showing that when there are important risk markers such as natriuretic peptides, then patients do worse. The higher their natriuretic peptides are, the worse they do. Same there for the calcification of the valve. We can quantify this now very easily with CT. And patients with a more severely calcified valve, of course, they do worse. What we should realize, however, is that it is not because there is an association with prognosis that it has been shown that intervening on these valves really is beneficial. So there are not that many studies, well, there are no big studies, which have shown that the calcification of the aortic valve predicts the response to an intervention, and this is much harder to prove, of course. There are a few randomized studies in asymptomatic AS. So the first important one has been published in the New England Journal of Medicine now 4 years ago, and this was a study in 145 asymptomatic patients with very severe aortic stenosis. And they showed that with early surgery, those patients did better. So they had less all-cause mortality or death from cardiovascular causes when compared to conservative care, where you can see that the numbers were a lot higher than 1%. So these were very severe aortic stenosis, so velocities higher than 5 meters per second. And these were mainly young patients with bicuspid valve. So this also explains why the mortality was quite low in the early surgery group. Number needed to treat after 4 years, only 20. There has been a second study, more in degenerative aortic valve stenosis. That's the Avatar trial. It has been published 2 years ago in Circulation. Again, a good 150 patients. Here, the Vmax was a little bit lower. It was 4.5. And therefore, this is also the number that has now been in the European guidelines to intervene on asymptomatic severe aortic valve stenosis. And so these were mainly patients with degenerative disease. Again, those patients with early surgery, they did better. And so these were patients, of course, who were operated, which might have slightly higher operative risks. Of course, everybody is looking forward a lot to this study, the early TAVR study, which will look in asymptomatic severe AS what TAVR can do. And with this low risk, probably it's going to confirm the results of the earliest studies with surgery, and it might even have a lower procedural risk, and therefore might be even better outcome. So long story short, I think that we are evolving rapidly to a situation where if we really clearly establish that there is true severe aortic valve stenosis, we're probably going to intervene earlier, irrespective of symptoms. But this is for patients with high flow or normal flow and high gradient aortic valve stenosis. Now, things become a little bit more complex when we have discordant measurements. And when we see patients who have low flow, low gradient aortic stenosis. So basically, these are patients where the valvular area is low, is low, yes, and also the gradients are low. And the typical scenario here is where the gradients are low because the systolic function is depressed. And what is recommended then in the guidelines is to do dobutamine stress echo. So why do we do this? This is because, of course, flow is very important to a gradient. And the higher the flow, the higher the pressures will become. And so if you have somebody with a really poor systolic function, then the flow over the valve will be lower. And for that reason, the pressure gradient will be lower, even though the valve might be severely stenosed. And what will happen when you increase the flow rate, if you have a true severe valvular lesion, is that the valvular area will remain the same, but the pressure gradients will go up. While if you have a pseudo-severe valvular lesion, the higher flow will open up the valve more, and you have some valvular reserve, and you might overestimate the severity of the valvular disease by looking at the valve area. So this is a typical case of classic low flow, low gradient severe AS. So you can see severely calcified valve opens up very poorly. And you can also see that the ejection fraction left is clearly depressed. It's an enlarged left atrium. So these are the measurements of the valve. So here you can see there's a low VTI at rest with only 12.6, corresponding to a low stroke volume index of 25 milliliters per square meter. And the gradients here are a peak gradient of 43 and a mean gradient of 28. So low gradients, but yet when we calculate the valve area, it is below 1, so it's a severe AS. But when you look at the flow over the valve, it's rather low, 182. So we should do a dobutamine stress echo in this patient. And we can, with that, identify two different scenarios. So either this is a true severe AS, and we will see the gradients increase, typically with a velocity above 4, and the valve area will remain the same, or the valve area was falsely depressed by the low flow state, and then it's a pseudo-severe AS. So here in this case, we did that. So you can see there is here the result with dobutamine at 20 gamma running. And so you can see that the LVOT VTI has increased significantly to nearly 20 with a normal stroke volume index now. And you can see that here the pressures are clearly elevated. Mean pressure is now above 40. There is some valvular reserve. You can see the valve area is slightly higher than it is at rest, but still this is a clear severe AS, and we should intervene in this patient also to improve the systolic function. So true severe AS. So it becomes even more difficult when there is limited contractile reserve. So in those patients who have such a poor ventricles that they don't have any inotropic reserve, there you can be in the situation where still even with dobutamine, you will not reach a normal flow rate of 250 milliliter per second. So what you then can do is calculate the projected valve area. So you just plot your resting area and your exercise, so your dobutamine stress area on a curve, and you measure the flow at both scenarios, and with a linear regression, you can extrapolate what is the projected AVA at a normal or standardized flow rate of 250 milliliters per second. So be mindful that you should have an increase in flow of at least 15% to be accurate. Of course, if there's hardly any increase, it is difficult even with this extrapolation. But you should ask in that scenario the question, if the ventricle is so bad that it couldn't even increase with 15%, then you're probably in a very bad scenario anyway. But projected AVA can get you out of jail there if you can get the cardiac output high enough to have a normal flow. Be mindful in those patients. These are very often patients who are very frail with a lot of comorbidities, maybe also some other reasons for heart failure other than the valve. So there is very often important competing risks in these patients. And even when you show that there is a severe AS, you should also question yourself what are the competing risks when you're fixing that valve, and is that still worthwhile to improve prognosis of the patient. Now, another important pitfall of stroke volume calculation is, of course, that it is highly dependent on how we measure the LVOT diameter. As you know, having a measurement which differs only 0.3, 0.4 centimeters, this can have a marked effect on what your valve area is going to be. So we should always be mindful that our calculations of the valve area, they are much more prone to error than the velocities or the pressures. And also it is so that the formulas we use, they assume that the LVOT is a perfect circle. And we know, of course, that this is not always the case. And we know it even better now that we are doing a lot more CT. So as you can see in this patient, it's very oval. And because of this eccentricity, you will markedly underestimate what the true LVOT area is. So this means that you should always have a good critical approach when you see an AVA which doesn't make sense entirely. And actually, there was a very nice study published. Our department participated to this study on pressure and area discordance. So these are over 4,000 patients with aortic stenosis. And what was very nice to see were two things. So the first thing that they showed in this study was that patients who had high gradients, they had pretty much the same prognosis, whether they had an aortic valve area which was higher than 1, considered moderate, or lower than 1. So the true severe AS, they had, so those with, that's the curve in red, who had high gradients and low valve area, they basically had the same outcome as the ones with high gradients and also a valve area above one square centimeter. So what they showed also in this study was that those patients with high gradient and a normal valve area, they also had very calcified valves when you looked at the calcification score on CT. And so therefore, this might change a little bit our current guideline approach. So in the European guidelines, there is still that when you see high gradients, you should exclude a high flow status. So it was true that in this study, patients with marked anemia, they were excluded. But probably this kind of hints that even when the flow is higher, or you're in a high flow state, if you have really increased velocities over your valve, then probably this means that there is some kind of a hemodynamic impact. And we might reconsider this recommendation of doing this systematically in any high flow status, and we might consider it as severe, respectively of what the valve area says. Now, the second important observation is in those patients who had true moderate, which is the green curve, versus discordant severe based on valvular area and low gradient. And you can see that those patients had a risk score which was a little bit in between. So those with a valve area lower than 1, but also with low gradient, they actually did better than those concordant severe AS. And in this study, about 74% had a normal ejection fraction. So a large proportion of those patients are what we call paradoxical low flow, low gradient severe AS. And so this is a different ballgame than the classic low flow, low gradient severe AS. So I think here in this group of patients, there is a clear need for more dynamic phenotyping. And so this means the interplay between valve area, hemodynamics, and what are the underlying diseases and comorbidities. And I think this is probably the best indication for exercise testing. And it is these patients with paradoxical low flow, low gradient, moderate to severe, I would say, AS that we all put on a bike at our center. So why do we do that? So there have been early studies in the early millennium, mainly by the group of Patricio Lancelotti, which have shown that when you put patients on a bicycle, you can identify those with a higher risk. He showed that the ones who increased their gradients with higher than the median, which was 18 in his study, they did worse. Also, those patients who developed exercise pulmonary hypertension, they also did worse. And he defined exercise pulmonary hypertension at that time as a systolic pulmonary arterial pressure above 60. Now, it's true that there has been some contradictory results. So this is another group by Gubler, published in JACC Cardiovascular Imaging. And basically here it's shown that when you base on the gradients at rest, there's a big difference between those with severe and moderate. But in this study, there didn't seem to be such a big difference between those with an exercise-induced gradient or those with pulmonary hypertension. So an interesting study is the one by Maréchaux in European Heart Journal. So basically, he found quite similar results as the group from Lancelotti. Again, the resting mean gradients are highly predictive, but also he found that when the exercise gradients increased above 20, similar to the 18 in Lancelotti's paper, those patients did worse. But a very interesting analysis that was done in this paper was to look at this exercise gradient in both groups with a low mean gradient at rest and a higher mean gradient at rest separately. And what you can appreciate here is that, of course, the ones with mean gradients that were lower than 35, they did better. But here in this group, The ones who had a higher increase in their gradient with exercise, they did better. And this is probably because here the increase in the gradient, it indicates an increase in the cardiac output. And so these are probably patients who have more cardiac output reserve. And so you can identify earlier on that they have a significant aortic stenosis lesion, but the prognosis here is driven not yet by the valve, but by the cardiac output. While if you look in this group of patients, they probably have less cardiac output reserve, and here when you see the increase in the gradient, this is mainly because of the valve. So this indicates that we should not look at a single measurement, but we should kind of have an integrative approach, looking both at hemodynamics and valvular lesions at the same time at rest and during exercise. This is why our approach has been for some years now to do a cardiopulmonary exercise test with simultaneous echocardiography. So we have set up a dyspnea clinic with kind of a standardized protocol. So patients come in for half a day. So in the morning, they get a lab test, they get a full lung function test, they get an ECG and an echocardiography at rest. And then we do a CPET together with a simultaneous echocardiography. So why do we combine the cardiopulmonary exercise with the exercise echocardiography? That is because both investigations give us very complementary information. So the exercise echo, of course, shows us the valve lesion, also the mechanism of the valve lesion, and it let us appreciate the left and the right ventricular function, cardiac output, the filling pressures, and most importantly also how these things changed during exercise, because of course many patients, they complain of exercise intolerance while they are quite good at rest. Now, the cardiopulmonary exercise test gives us different information. So we have the peak oxygen consumption as a very objective measure of exercise capacity, but it also shows us if there's something wrong with the lungs. Is the limitation of the exercise maybe more lung functional, or is it maybe in the peripheral muscle? So they give us a lot of information on that, on the ventilatory efficiency, and on really the true mechanisms of dyspnea. Is this only the valve, or might there be something else? So this is basically our protocol. We start with a comprehensive measurements at rest. So we do a set of 10 images, and this includes the LVOT for the cardiac output, the mitral filling pattern. This includes grayscale imaging, of course, the valvular measurements, and then basically also the pulmonary pressures by the tricuspid regurgitation signal. So we do this 3 times before at rest. Then we let the patient start with a continuous ramp protocol, which is based on what we expect that they can achieve to have a test which is between 10 and 15 minutes. And then when they are at the first ventilatory threshold, but with a heart rate which should be below 100, we do a first hold stage. So here the wattage remains the same, and we do a second set of images. And then when we have this set of imaging, we let them continue to exhaustion, and then at peak exercise, we do the last set of imaging. So also because we have the CPET, it is very easy to follow the patient and see when he is near maximal, because we can base this on the respiratory exchange ratio. So it also helps you with the timing of your images. So 3 phases. This can show us whether we have a cardiovascular limitation of exercise. So this is something we want to see when we think that the heart is the problem. So we try to achieve RERs above 1.1. In some patients, especially very older one, we need to be happy with higher than 1. So if there's a clear objective reduction in the peak oxygen uptake lower than 80% of what's predicted, then this means that the patient has a reduced exercise capacity. capacity. And typically when the cardiac function is depressed, the cardiac output increase should be lower than 80% of what is predicted. And we also have some CPET clues to see that. So one of the things we can look at is the oxygen pulse. In a cardiac limited patient, we can see this corresponds to stroke volume. So we see a plateau phase here. Typically, we also see that the first ventilatory threshold is quite early in those patients with a cardiac limitation. And then the VE VCO2 slope should be above 30 in those patients. Very important measurement for our hemodynamics are the pulmonary pressures. And we can measure them in more than 90% of the patients, but we should do something. We should give agitated gelofuscin. With a little bit of air, we make some micro bubbles and we infuse like 1 cc. And here you can see that this is a patient where you can appreciate that there's virtually no TR, so no signal at all. And from the moment we inject only 1 milliliter of agitated gelofuscin, we can clearly delineate the signal for the pulmonary pressures. And actually, this is a study that at the same time measured the invasive pressure, and there was a very good correlation. So in more than 90% of our patients, we can measure it accurately through agitated gelofuscin. Of course, the second important measurement is the cardiac output. This might be a little bit harder, but it's certainly achievable. So here's an example of a patient with LVO2 at rest and during peak exercise. What we know is that when we do it on an exercise echo and we compare it to gold standard MRI measurements, at peak exercise, we tend to underestimate a bit. This is, of course, because our alignment might shift a little bit with the respiratory variation. And for this reason, when we measure the LVO2 at peak exercise, we don't average over different cycles, but we typically take the highest signal because the highest signal is most of the time the ones with the best alignation. Of course, when you have a lot of ectopy, this might become a little bit more difficult. And what we have shown, this is a paper that has just come out, is that when you look at not the absolute pulmonary pressures, but you look at the pressure over cardiac output slope, and this is really the same slope based on invasive hemodynamic measurements, you can see that that patients who have a high slope, they do worse in terms of relevant prognosis, cardiovascular death, aortic valve replacement, hospitalizations, or new onset atrial fibrillation. And this was basically independent of and stronger than the absolute systolic pressure measurements. Now, the question, of course, then becomes, if we see this pulmonary hypertension during our exercise testing, is this due to the valvular lesion? And there we also did an interesting analysis. So this is nearly 300 patients with moderate to severe AS. And so we basically stratified them in two groups, 2 times 2 groups. So what we first did was we based the severity of AS on a velocity higher than 4 at rest or at exercise. We basically did the same for the valve area as well in a sensitivity analysis. But this was our main analysis. And then we looked at their underlying HFpEF profile, and we used the established H2 FPEF score for that. So this gives you a probability of underlying heart failure with preserved ejection fraction. And so we had basically 4 groups. We had those with severe AS and high HFpEF score, severe AS and low HFpEF score, moderate AS and high HFpEF score, and moderate AS and low HFpEF score. So, and what we saw was that when we looked at the left atrial function, for instance, that basically those patients with HFpEF, they had a clearly impaired left atrial function, while those with severe versus moderate AS, they didn't necessarily have a difference, and there was not a significant difference being seen in either the reservoir or the booster pump function. when we looked at the hemodynamics, it became even more interesting. So when we looked at the MPAP-CO slope, and so we know that this is a very prognostic marker now in aortic valve stenosis, it was basically more the HFpEF status which determined the slope than the valvular severity. So you can see here that those patients with clear HFpEF, they had a high slope, irrespectively whether the lesion was graded as moderate or high. While those with a lower HFpEF score, they had lower slopes, yet it didn't make out whether the lesion was moderate or severe. Also, this was associated with the peak oxygen consumption. So you can see that the peak oxygen consumption, it was significantly worse in patients who had HFpEF, but it was not different between those patients who had severe versus moderate AS. This let us thought, what is now the reason for this poor association? An interesting group to look at might be those with mild aortic valve stenosis. So these are all patients. This is a study from when I was at Mayo Clinic. These are all patients with proven HFpEF by invasive hemodynamic measurements. So they either had a wedge higher than 15 at rest or higher than 25 during a supine cath lab test during exercise, all proven HFpEF. And what we did was we looked at the presence of mild aortic valve stenosis or even absence of valve stenosis, but valvular sclerosis, calcification. And so what you can clearly see is that even though these lesions would not be expected to have a significant hemodynamic impact, still there was a lot more stiffer ventricles in the group who had aortic valve calcification or mild aortic valve stenosis. And this is probably because one of the drivers of even degenerative aortic valve stenosis is inflammation, which we also know that is present a lot in HFpEF, especially in obese HFpEF. And this was also something which was shown by the baseline characteristics of those patients. And interestingly, those patients with aortic valve sclerosis or mild aortic valve stenosis, they did a lot worse. They did significantly worse in terms of survival or readmission for heart failure. So this also shows us that when we look at things like calcium score, we should be wary because, of course, higher calcium scores, they are associated with worse prognosis. But does this necessarily mean that when we are going to operate on that valve, that we are improving the prognosis of the patient? We should probably show that more clearly because the association with prognosis is not the same as a surrogate for treatment response. And so what I like a lot is that idea that has been published also recently by Jenner and the group by Pibaro in JACC of the extravalvular cardiac damage stages. And so basically their hypothesis is that when it's only the aortic valve and there's no cardiac damage, it gradually progresses between the cardiac chambers. So the first chamber affected by the aortic valve, it's the left ventricle. So you get hypertrophy, high filling pressures, eventually an ejection fraction below 50. Then the second chamber which will get affected is the left atrium. So it progresses and then go through the pulmonary circulation, and eventually also the RV function will go down. And this extravalvular damage has been clearly associated with prognosis. So here is a study, nearly 2,000 patients. So they classified them according to the extravalvular cardiac damage. And as you can see, if you go up the stages, if you look after aortic valve replacement, with higher stages, you get a lot more patients who are dead or in a poor quality of life after the operation. So this means that you should probably intervene on those severe valves early enough before this extravalvular damage occurs. Now, another thing, and this is where I think it becomes really interesting for the future for doing more studies, is that they showed that after aortic valve replacement, there was only 15% who had a clear improvement in their cardiac damage. This could mean either that we were too late in many of those patients to intervene, but this could also mean that some of these patients might have extravalvular cardiac damage, which might have been due to comorbidities and other reasons. And this is also an important reason why you should really phenotype those patients well and also exclude other things, other risk factors for HFpEF, and really tackle them before you conclude that it is really the valve that is the culprit, especially when you cannot show that the valvular lesion is severe. And that is our integrative approach in a dyspnea clinic. We know that when we do it like that, we find a lot of patients with HFpEF. We recommend them for further diagnostic exams, nearly all of those. We might find some patients who are suspect for amyloid, who might have a cardiomyopathy underlying, refer them for additional diagnostic tests. We change in almost every patient, we change cardiovascular drugs, often a lot of them. We treat comorbidities. Many of those patients are iron deficient. Many of those patients are obese. We have treatments for that now. Sometimes we do ablation procedures or refer for other cardiovascular interventions. And of course, also for rehabilitation and training. I want to conclude to what I think might be, and it's a little bit of a risk, but I'm looking a little bit in the future of what might become a simplified guidance how to tackle aortic stenosis in the future. So when we encounter calcified aortic valve disease, the first thing we should do is look whether there's clear severe AS at rest. And I would argue that for this, we should remain to look at the Vmax or the mean gradient. So if the Vmax is above 4 or high, mean gradient higher than 40, this is clearly severe AS. And we should probably in the future not wait anymore for symptoms to occur. If it's a patient higher than 70 with a life expectancy higher than 1 year, we should be okay to put him for TAVI. It's a lot. If it's a younger patient, still, I think we should have a decision whether it should be surgery or TAVR. But if there's prohibitive risk, we're more and more inclining towards TAVR. So these are the easy cases. Then there's, of course, the classic low flow, low gradient AS, so low valvular area, but also low gradients in a patient with clear systolic dysfunction. Still, I think the dobutamine stress echo is a really nice exam to differentiate between true severe AS and then basically we are back to that other situation. In those patients, most of the time we will go for TAVR because, of course, those are high-risk patients. Or we end up with pseudo-severe AS. And so this is then most of the time moderate AS. I think we need more data on those patients. But if there are any patients with moderate AS where we should intervene on, then it's probably those patients who have a severe impairment of their systolic function and who are really afterload dependent. So there are studies coming on that. The evidence is not yet there, but I think eventually we might end up also going for TAVR in some of those patients. Then there are the patients with clear moderate AS. I would say if the velocity is below 3, you should be very careful to decide to intervene in this patient when there is a normal systolic function. So there are a lot of moderate ASs with a low valvular area where the valvular area is probably not really well measured. So in general, I would think that patients with a Vmax lower than 3, they should have conservative treatment with follow-up. And then there is CPET echo, basically for everybody with a Vmax in between 3 and 4, or those with paradoxical low flow, low gradient. And then when you can objectivate a severe AS by having high gradients during exercise or a projected aortic valve area below 1 at 250, then you should probably go for TAVR. Many of those patients, they have high risk for patient prosthesis mismatch. So probably this will become a good indication, especially for self-expanding TAVR rather than balloon expandable. And then very importantly, the CPET echo doesn't only give you information on the valve, it also gives you a comprehensive assessment of other mechanisms for dyspnea. And especially when you cannot show that the lesion is severe during this exam, you should probably search for other mechanisms and treat them first before you consider to intervene on the valve. Because we probably also intervene nowadays on symptomatic moderate AS, where the symptoms are more likely due to HFpEF than due to the valve. And this is a big difference with Braunwald's early paper with young people with rheumatic heart disease, where the ventricles were very healthy. Here we sometimes also see things like hypertension, diabetes, inflammation, obesity also impacting on the ventricle. And then we see a moderate AS and we think it is the AS, while it is really the ventricular disease. Thank you for your attention, and I'm happy to take questions.
Thank you very much. That was an amazing lecture in a very complex topic. So please put your questions in the Q&A and we'll go through them one by one. We'll have CME also that we'll see now on the screen. So I'll start with a question, and you mentioned about the higher risk of the patients with moderate aortic stenosis that has been reported in multiple studies, including the trial by Linda Gilliam and Philip Gennaro. So what should we do in these patients? You didn't put them that much in the CPET group. Should we be doing cardiac MRI? Should we be studying these patients more? And I really like how you separated the causality versus correlation and connectivity, and the things that will increase mortality in the patients, but that doesn't mean it's because of the valve, and that if we treat the valve, maybe they will die more. So that becomes very tricky. So what do you do with the moderate AS in general?
So I think when the moderate AS is clearly moderate, so with a Vmax below 3, so moderate or even mild, I think you should be very wary to attribute any symptoms to the aortic valve, even when there is a lot of calcification of the valve. And I think the good thing about the CPET is that it gives you a lot of information about comorbidities, and I think at least you should treat all of them and then maybe reassess. So I think there it should not be the case. I think in the group with a velocity between 3 and 4, there are clearly some patients where there is hemodynamic impact. And I think then there the exercise test becomes very important. If you can show that during exercise there is hemodynamic significance of the aortic valve, then I think this is your best shot at the moment to predict that when you're going to intervene on that valve, you're actually also going to see an improvement in the myocardial function, because this is what you want to achieve in those patients. I think we need definitely more phenotyping and more studies before and after valvular intervention to show what are the exact predictors of which extravalvular damage has been caused by the valve or which is concomitant caused by other disease. I don't think we have the final answer there yet, so I cannot give it to you. I think this is a really important topic of further study.
Yeah, and we have the progress trial that will come, but we have to wait until the mid-2030s, right? So it will take some time to answer that. We have Dr. Garcia also here. Thank you for joining us. If you'd like to go with the next question.
Frederick, that was a very impressive talk. I like very much your approach and your comments about how important it is to determine what is flow at the time of assessment. And I do have a little bit of a disagreement with some of the positions that we have right now related to management of patients with severe AS that are asymptomatic based on the velocity. In part for that reason, it's because the velocity obviously is flow dependent. But when you look at the data of clinical trials which are looking at event-free survival, the most common event by far is surgery. And the referral for surgery, in many cases, in many of the studies, it's unclear to what are the proportion of patients that are indicated because of heart failure symptoms versus just some vague indication. Sudden cardiac death is very rare, less than 1%, unless there is low EF or in the very rare group with the velocity of more than 5. So I wonder whether, although we recommend intervention in asymptomatic patients with velocities of more than 4, whether the data is robust enough to justify that.
Well, I think the cost efficiency, that's an even harder thing to tackle. I think when you look pure at the efficiency, I think that we see that with TAVR, and especially newer generation TAVR, or threshold should gradually decrease. If the risk decrease of the intervention, then we should also lower our bar, I think, for intervening on those patients, because what I think in those patients, you want to intervene before you get cardiovascular damage. But I agree that also in these patients, we very often do in those asymptomatic severe AS, we do the exercise testing because then you might detect symptoms, of course, a reduced VO2, but what you also might detect is impacts on the hemodynamics, on maybe the atrial function, maybe on the MPAP-CO slope, which could lead you to think, I agree that this is not 100% perfect, but that this is not an ideal situation for the heart. And over time, damage will occur. And then I think it is valid to intervene if your intervention is a really low-risk intervention, which TAVR is increasingly getting at. But yeah, your point is well taken. Of course, there's also a cost at that, and we should probably also calculate whether if the gains are small, then the costs are relatively high. So these are all very good questions where I think we should have more study on.
So let me make another comment regarding what you mentioned about flow. I think that's important. One scenario where I think that being quite unique are in patients that present to the hospital with acute blood loss, where you have someone who had a relatively moderate AS and suddenly you get an echo and now the AS is severe. But in truth, as a matter of fact, once the blood loss is corrected and the anemia is corrected, the velocity goes down to their baseline. And we see that a lot in patients that have acute hip fractures with AS. And when you look at data from Mayo Clinic, that surgery is very safe. They are based on their definition of severe AS on velocities. But there are other studies that have based severe AS on valve area, in which case the mortality is higher. So I think that's it. There are many scenarios when your point is well taken, where it's very important to consider flow before classifying the AS severity.
But I think what we also should realize is that yeah, I don't know if you're probably at one of your expert centers with also in the US. I have been in the US. You have very good image qualities in all echoes, like every echo is like 70 images. In Belgium, this is not always the case. So errors are frequently being made in valve areas. And I think this is, of course, we base on our guidelines on clinical excellence, but we should realize that it is for the average practitioner, it is a lot more difficult to get an accurate area than an accurate pressure or velocity. So, and I think by doing the exercise quite systematically in everybody who is moderate to severe, at least you get, if the area doesn't fit with what you're seeing during the exercise dynamically, you start questioning the area. And I think this is also one of the reasons why you're phenotyping your patients better, because you have multiple parameters and you want to fit them all in a story which makes sense. And then you find also your measurements which are probably errors.
Thank you very much. We have a few more minutes left and a few questions, so we'll do kind of quick questions so everyone goes home happy today. So from Rob Osfeld, outstanding talk. Statins have proven to be ineffective on halting aortic stenosis, at least starting midlife. Given the similar architecture of aortic stenotic valve and atherosclerosis, do you think that adopting helpful early lifestyle changes could change the incidence of aortic stenosis?
What I think actually is that when you look at some papers, you see that having severe obesity, that is probably a risk factor of developing aortic stenosis over time, because one, you need a higher cardiac output, so you have higher flows over that valve for a lifetime. It's also associated with inflammation. So I think that, but I'm now a little bit hypothesizing that tackling obesity might delay the development of degenerative aortic valve disease. And maybe, of course, there are now a lot of molecules also tackling the inflammation within obesity. I always think you should treat causes, and most of the time when you take away the obesity, also the inflammation goes down. But maybe there's something there which might work as well. But if I have to say one lifetime, one lifestyle prevention measurement which might make an impact, and it's tackling obesity.
Thank you very much. Question from Daniel Lorenzati. What about the aortic valve calcium scores? You mentioned them in some of the trials, but you didn't put them in your pathway. Do you use them?
So I am very careful to send somebody to surgery based on purely a calcium score. So we of course we like that because it's very easy. We get a number, we get a cutoff, and it's simple. We don't have to think anymore. So I really want, even in somebody with a high calcium score, I really want to show that there is hemodynamic significance, hemodynamic impact, either with an echo CPAT or maybe even in the cath lab. And this is especially true for patients with bicuspid valves who might have higher calcium scores. And you want to intervene at the right moment in time. So I think that, yeah, sure, there is an association between calcium score and prognosis, and sure, there is also a correlation between severity of valvular calcification and severity of valvular stenosis, but this correlation is not perfect. And even if you would assume that it is 0.9 that correlation, that means that if you take the quadrant of that, it's 81%. You're in 1 in 5. You end up at the wrong side of the decision. So I think it can help you. It can help you especially in those who have limited or no contractile reserve, because these are very hard to quantify. But you shouldn't make your life so easy that if it's a little bit difficult, you just go for the CT calcium score and you decide. I think that's a little bit simplistic.
Thank you very much. From Mike Fatou, he's interested in your dyspnea clinics. Can you mention which specialists are involved, how many patients you see in the day?
Yeah, so we have done this in collaboration. It's mainly by our cardiology department. We have some collaboration with pneumology. Ideally, you would have a joint venture there, but my experience is that it most of the times originate from either the pulmonology or the cardiology department. But we have them involved to do the lung function test. We have them on every patient, and this also helped to get a clear picture of the pulmonary comorbidity. We have one operator cardiologist who does the echo. We have one, this is at our place, the heart failure nurse who operates the CPAT and also gives the agitated gelofuscin. And then we generally have a fellow who might be in there doing the image and or looking. But basically, you can do it with one person doing the echo and one handling the CPAT. And then the test itself doesn't take too long, like installing somebody on the bike and doing the exercise test in half an hour to 40 minutes. We do the test, but we analyze a lot, so this takes at least an extra hour of work. Yeah, we do 3 in an afternoon. And we do that two times a week. So we have 6 slots a week at our place.
Thank you very much. From Min Poo, he says, this is the best talk I've had in the past 5 years. Says you're a true expert in AS and have more knowledge than other people that he has seen. He says excellent valvular center is not just on the numbers, but understanding the pathophysiology of valvular disease like you've demonstrated. So I think with that phrase, we can end the lecture. And so thank you very much for your time, and hopefully we see you in New York. Please let us know if you're around.
Yeah, very kind. Thank you again for the introduction. And I think the last thing, it is true not only for AS, but for everything in medicine. The most important question is why.
Thank you very much.
Okay, thank you very much. Have a great day.
Bye-bye.
Bye-bye.